Did you know 40% of women that get induced to go into labour end up with a caesarean? That's right. That's the statistics we're looking at. So today I want to share with you what the cascade of intervention is and how you can avoid it. Because knowledge is power, right? I'm not sharing this information to scare you, but where I come from as a natural birthing, childbirth educator, I believe it's really important that you learn everything about birth and how the cascade of intervention can come into play that can totally derail you from your natural birth experience. I'm Gabrielle Target. I've been a doula for 28 years and I'm a natural childbirth empowerment coach, I guess you could call me. I've been around for a long time. I've attended over 450 births and I've seen it all. And I have worked with women who have been induced for whatever reason. And I know what it takes to keep women off the cascade so that they end up having a vaginal birth even though they do get induced. And that's what's important here. You can jump ship, but you have to know how. If induction is something that you have to go and have, there are ways in which you can prevent it from cascading so you end up with caesarean. And I'm going to share those ideas with you now. So why do women get caught up in the cascade of intervention? Well, it does start with induction. So unfortunately, women can be their own worst enemy. They're impatient and they want to sign up to have their baby or their labour induced because they don't want to wait any longer. So women can actually create this cascade and getting on this road that they can't jump ship from. Now, I think it's important to note here that if you can be patient and allow your body to go into labour naturally around your 40, 41 week mark, brilliant. Don't forget the EDD is an estimate. It is not your due date. And if you go past it, there's something wrong with your body. Okay, the EDD is an estimated date of delivery. Okay, it's not set in stone. It's give or take 2 weeks. Sometimes you just need to be patient. Now, if there's a medical need for induction, often women go in, they will have prostaglandin gel put into their cervix, which can efface your cervix beautifully and get it nice and ripened up, nice and soft and squishy, so that in a given time frame, 6 to 12 hours, then the membranes can be broken because your cervix is soft enough to place the applicator up inside your body and break the membranes artificially, which is known as AROM, artificial rupture of membranes. That is what they like to do, the medical establishment, to get things going. Now, going back to being induced, some women are so terrified of labour, which is such a shame because fear has no part to play, that their body won't actually go into labour naturally. So they push labour away because of the way they're thinking and feeling, and they're terrified about labour. So that can be another reason. Another reason to be induced is because maybe your obstetrician says you're not going to go past this date. I'm not going to permit it. I want you to have an induction before a date. Now, that's up to you whether you decide to go with that or not, but I would highly recommend that you push to have a bit more time if you can, if there's no medical problems at all. Because the body needs time. You need time, mentally, physically, emotionally, to get your head round going into labour. Now, also, an induction can occur if your baby is posterior because it tends to push you past your dates and you don't actually go into labour because the baby's circumference of the head, the broad brim, doesn't connect with the cervix, making your labour be pushed away. So you're less likely to go close to your estimated date when you do have a baby in an unfavourable position. That's why optimal fetal positioning is so vitally important. And I've created a video on that because you need to be doing exercises from 30 weeks on to get your baby's spine to the front of your body, 100%. And that really is imperative for you going into natural labour. So let's go back to, okay, you're being induced, you're on this road of Cascade. Unfortunately, you've had the prostaglandin gel inserted into your cervix or maybe suppositories, and now you wait. When your cervix then has been given an opportunity to thin out and efface, your membranes will be broken artificially. Some establishments will enable you to have a period of time now, a window in which to go into labour naturally. Maybe 6 hours, maybe 3, maybe 2, maybe 1 hour. It varies from hospital to hospital, facility to facility. So I can't tell you how long you'll be left to your own devices to go into labour naturally. So a small percentage of women do actually start contracting. And they do very, very well. And they can then continue contracting, get to full dilation, have vaginal birth, which is, yay, awesome, because they've jumped ship off the cascade of intervention. They've won. They've done it. A large percentage of women, though, do not go into labour because maybe they're fearing they've got catecholamines on board, which are the adrenaline hormones, and they're really pushing labour away. So they're not serving them at all. So if this is the case, some further interventions are going to need to take place to get you into labour. This is normally putting up a drip of Syntocinon. If you're here in Australia, it's called Synto. If you are in the US, it's called Pinto. Pitocin is the drug that drives your uterus, and depending on your establishment, where you're birthing, as to how they deliver that into your body, how they drip it into your body, over what time frame and how regularly. So some women are given a beautiful opportunity to go into labour naturally and steadily up into established labour, so they get a good warm up and then go into established. Some women go from 0 to 1,000 in an hour, unfortunately. So that is problematic because it's so hard and fast, and it makes you work so hard and fast, and the intensity is a lot to cope with. So a lot of women have to go some form of pain relief. They can't not. It's too much for their body to cope with. Hormonally, they can't catch up either. They can't jump into oxytocin and endorphins because they can't relax, they can't let go, and they certainly can't surrender, and they can't find their breathing rhythm. That can be really tough. This is when women then cascade into the next level of the cascade of intervention. So what happens here is women need to go some form of pain relief, as I said. So if dilation's slow and women are tired, which often women are tired because they've been up for already 48 hours before they've gone and had this procedure of prostaglandin gel and their membranes breaking, they might not have slept for 48 hours or 24 hours. They're already tired before they're running their marathon. And this being the case, they might go pethidine or morphine to help them sleep through the small stuff, the early stuff. But a lot of women find that just makes them sick, and there's side effects of that. They're drowsy, they hallucinate, they can't focus, they feel absolutely shattered and all over the place. So do your research on those particular drugs, because often they don't serve women well. Now, gas at this point is also too early to be sucking on. It will dry out your throat, and it is not a long-term choice. So this is where I guess suggested that you have an epidural, so that you can then have your uterine muscles contracting with the Synto or the Pinto on a regular basis. They can turn it right up and get you into established labour quickly whilst you can't feel it. So you're anaesthetised from under your chest down. But what happens with the epidural? that's problematic is often you are bound to the bed, you are bound to machinery. So the fetal monitoring straps go on, your uterine contractions are monitored, as is baby's heart rate. Now you're at the mercy now of the epidural and whether your blood pressure takes a dive or whether baby's heart rate takes a dive. So either one can send you into theatre very quickly. Just know that. The other thing is optimal fetal positioning can go out the window because you're now in the bed, usually reclined. So baby does that rotation of spine from belly, being on your belly button. If you're on your back, rotates to spine to spine. It makes it problematic when it comes time to push and birth your baby. This is how the cascade really does flow and more interventions take place. Now, you could jump ship here though. You could have your epidural, you get to full dilation. Guess what? You got the urge to push. You get up on your hands and knees because the epidural wears off and you birth beautifully, vaginally. And you have enough sensation to push your baby out of your body. That is where you can jump ship. Yay! You've done it. You've fully dilated your body open. You have done so well, and you give birth. Where it comes unstuck, though, is a small percentage of women, this doesn't happen. The baby rotates, doesn't come down onto the cervix doesn't open. So you are told you're failing to progress. So the dilation remains stuck for hours and hours and hours and you don't dilate open. Probably because the baby's head's not applying pressure. As I said, posterior baby's head, broad brim, front to back, isn't favourable for putting pressure on the cervix, so it doesn't help the cervix to open. You might be fearing. You might have a lot of anxiety and stress, so your catecholamines, adrenaline-based hormones are up, and your cervix will not open under those conditions. True fact. So what has to happen here is one of two things. Either you go to theatre and you have a caesarean because you have failed to progress and your body's not doing what it should be doing, maybe because you're exhausted as well. So that is where you might go and have a caesarean, or baby does go into distress, baby's heart rate drops, you've got such a heavy epidural on board, you can't feel a thing, and they say, we think it's best for us to take you right now to theatre. Now, an emergency caesarean is one where baby's heart rate has really dropped and baby's needing to come out immediately. A caesarean by necessity is where you've failed to progress, there's no urgency, they're going to take you for a caesarean and it's all relaxed and calm. So there's two types of caesarean. Not all caesareans are emergencies. Just bear that in mind. Some are through medical cascade of intervention necessity. So just know that. They're not always crazy and they're not always like, you're running down the corridor like you see in the movies. They're not like that at all. They can be very relaxed and calm. It just means that for whatever reason, your body has chosen not to open. Now, another reason for having a caesarean is if your cervix starts to swell and you get an anterior lip, which is like a donut around your cervix, which won't shift back and it prevents the baby from coming through your cervix. So that might be another reason to have a relaxed caesarean by necessity if you have an anterior lip. Now, let's push all that aside. You have opened up fully, your baby's coming down, but progress is very slow down through the birth canal, and your obstetrician or the medical people that are supporting you say, we think we need to give you a hand, or you might be really exhausted and you can't push because it's been hours and hours, because having an epidural with a labour can really stretch out your labour journey and make it very long and slow. So just know that. With that in mind, you might not be able to push. The forceps might need to be inserted in to help pull the baby down into the birth canal. And then the vacuum goes on baby's head and baby is pulled while you push. And you will be given an episiotomy of your perineum to help create the circumference that is needed to bring baby's head through. Because don't forget, you do not have oxytocin and endorphins on board, because you've got the block, the epidural block, that shuts out and blocks out your oxytocin and endorphins, unless you let it wear right off, and then you might have a chance for that to come through at the end. But usually in theatre, there's no opportunity for that, especially if there's been forceps and then vacuum. So you more than likely will end up with an episiotomy. And then what happens is you have stitches to repair that area, and your epidural might stay in for quite some time to help you just to heal. There's 3 types of vacuums that could be used. So there's a little kiwi cup, which is a little plastic cup that goes on baby's head, and they just do this little suction with their hands and put enough pressure on the baby's head with this little tiny suction cap, and as you push, they pull. Or there's the ventouse, which is the big metal suction cap, or there's the nice soft rubber cap that they use. Any type of vacuum or forceps usually will come with an episiotomy, unfortunately, and then you will have to be stitched from that. Some women choose to tear naturally because a natural tear can heal better than a blade cut. So just know that you could have a choice with that. Maybe it depends on your stretchability of your perineum and your vagina. They're the ways that the baby could come into the world. So you have caesarean back, where we spoke about, where you failed to progress or as a medical necessity. Now, some women may come down this road of having the vacuum and the forceps, but the baby is still stuck and they cannot get the baby out. So what happens in that scenario, very rarely though, it goes back across to caesarean, and they literally do a caesarean to help baby come out, because baby's obviously stuck and not going to come out vaginally. Unfortunately, that is, I guess, your worst cascade of intervention that you could experience. That's really taking it down a road that I wouldn't wish on any woman at all if that happens. So as I said, knowledge is power. I come from a place where I like to teach the natural birthing model of birth, because I come from that place as a labouring woman myself who's had 3 home water births. The other end of that spectrum is the techno-medical model of birth, which I've just explained to you, where you really have no control over what goes on. You are at the mercy of the drugs that you choose to take and the interventions that are placed on you. I feel that if you learn about both and you meet midway, you've done well, because then you know everything you need to know about. If it does go that way, needing medical interventions, you can choose then what you do. But I would focus all your energies on spontaneous labour beginning, baby being in optimal fetal position, and you be patient and you wait for your baby to come into the world. You wait for your body to labour spontaneously. That's where I would come from this natural birthing model. But everything's about choice, and you've got lots of choices. And don't forget, this is about education. This isn't to scare you. The cascade of intervention is real. You can avoid it by staying off being induced. Being induced is what begins the road of cascade of intervention. So if you avoid that, you avoid this whole scenario playing out. True. The World Health Organization states that women should not be induced until they're 41 weeks pregnant plus. Patience needed. I know women feel the EDD is the estimated date they should be going into labour. It's not. It's give or take 2 weeks. Be patient, ladies. As Michelle O'Donnell says, the famous obstetrician who specialises in water birth, a beautiful French obstetrician, he says, when the apple is ripe, it falls from the tree. Is that right? So when you are ready, your body will go into labour. True. All right, that's it from me today. My wish for you is that you create the most beautiful labour of love and create the birth you want and desire. Bye for now.